Good morning, everyone. Thank you for allowing me to participate in this conference, Jeff and Derek. For those of you who don't know me, my name is Eric Hansen. I'm on faculty at UCSF, and it's my distinct honor to share the stage with a share the stage with the three surgeons on my left. I think the co-chairs chose them because they kind of represent different stages in career, but also diverse clinical practices and geographic locations. So to my immediate left, we've got Keith Fehring, who's at Ortho Carolina and probably is the new kid on the block, so to speak. To his left is Alfred Kuo, who's been operating, for 15 to 20 years and works at the SFVA as part of our UCSF institution. And then to his left is, obviously needs no introduction, Jay Parvizi, who is now, I guess, Professor Emeritus from the Rothman. So congratulations on that. So this journal club's a little bit non-traditional, and not in the sense that I experienced at the Rothman Institute, where we did this over hookahs and ice cold Patron, but a journal club where we're not going to dive into the details of any given article, but really use them as a platform to discuss some relevant topics in primary total knee. Sorry, which one do I push? Okay. These are my disclosures. I'm a consultant for Corin's robotic knee platform. Sorry. So in terms of primary total hips, I think that there's really no debate. There's one way to do it. It's the Hozak style. It's direct anterior, off table, cementless, dual wedge taper, stem, Biolox Delta, and highly cross-linked polyethylene. But I think in 2023, primary total knee is still hotly debated in terms of the various topics here. I'm going to try to get us back on time, so we may not be able to go into each of these specific topics, but we'll start with fixation. And to my panelists, these are not trick cases or anything, very straightforward, but we're going to talk about some of the underlying ideas behind how we do total knees. So this is a 59-year-old man, had an open meniscectomy many years ago and a subsequent arthroscopy, hypertension and a BMI of 30. So just in terms of fixation alone, what would be your fixation choice for your primary total knee, Keith?
So for primary total knee and a 59-year-old male, I'm going to use cementless fixation, or going with the plan of cementless fixation. Always have the ability to bail, but pretty much for males, anybody under the age of 65 to 70, I'm doing cementless total knees these days. Females kind of a little stricter with sort of a lower age range, but certainly pushing the males up to about 70, women under 65.
Alfred?
Eric, do you mind if I give a little bit of background on our thinking?
Sure.
As we discuss this. So if you look at cementless fixation, and that's the question, right? Cementless versus cemented. You look at institutional studies, there are a lot of institutional studies that show good or better outcomes. If you look at large populations, it's probably a little less effective. If you look at subpopulations, probably obesity, and in younger patients, there may be an advantage there. But we're very traditional. We cement just about everyone.
Jay?
Yeah, cemented total knee replacement, and this might be one that I would not resurface the patella.
Can I just poll the audience? How many of you are using cementless fixation for your primary total hips?
Knees.
Hips.
Oh, sorry, knees. This is a primary total knee. And of those who do cementless total knees, does it represent more than 50% of your total knees? No. Okay. So we kind of touched upon this. Jay, did you ever do any cementless total knees, or were you all cemented?
All cemented, and I'll wait for data to justify its additional cost before embracing it.
And Keith, it sounds like you have some indications for cementless fixation, basically gender and age primarily.
Correct. So probably about 30% of my practice right now is cementless total knees, and kind of gauge the age ranges and gender, and just kind of subjective bone quality intraoperatively.
So this is the first paper I wanted to present. It's called Cementless versus Cemented Total Knees, Concise Midterm Result of a Prospective Randomized Controlled Trial. And this was actually sort of the 6-year follow-up of an original 2-year paper, basically using the same total knee design, and the outcomes were both clinical and radiographic. They documented survivorship in 100% of both groups with no radiographic loosening. There were no difference in PROMs, and the only statistically significant finding was that in a single question about satisfaction, there were a higher percentage of patients who were either extremely or very satisfied in the cementless group. So my question to the panel is, does it make sense that we're following these to 6 years? If we were talking about failure of fixation of a primary femoral stem, it would happen relatively early. So what is the value in following cementless fixation for 6 years?
I think you're absolutely correct, Eric. If you're really trying to make a difference, you got to look at the long-term outcome, the 10, 20, 30 years. Because I've heard the cementless people arguing that cement is the strongest in the OR and starts to weaken over time. But it has performed well. Survivorship of cemented total knee replacement in the Swedish and the Australian registries is still better than the cementless. And at this point, in my institution, cementless is almost 2 times to 2.5 times the price of cemented. And having just listened to all the issues that we're dealing with today with Medicare, is the additional cost justified to see that improvement in outcome and survivorship? I remain unconvinced, but I'm obviously open-minded and I'll wait for the additional data. But the additional data, to your point, has got to be the long-term data. The 1 year, 5 year, 10 year is probably meaningless.
Do we really think that fixation leads to difference in patient-reported outcomes? It seems to me that it's a survivorship, revision, reoperation variable. So why are we collecting all of this patient-reported outcomes?
And if you look at this paper, I remember reading this paper in detail. There is actually a difference between that 84 versus 66% is almost 2 patients. And because this patient sample size is so small, and how you define extremely satisfied versus non-satisfied. So we have to be careful about making sweeping statements like there were more patients satisfied with a cementless knee than cemented in a small cohort whose primary intention was not to look at that endpoint at all.
Yeah, absolutely. There's, I believe, fragility indices where you can look at your methods, and small numbers can lead to very different conclusions. In addition, there's oftentimes spin in how results are reported. So just reading the abstracts, like I unfortunately often do, you probably don't get the same understanding as if you look at the data. With regards to multiple outcomes, you'll see in many cases that if you have enough questionnaires that you're distributing, you're going to find something that has a difference, and then that's going to be spun into the main outcome of your study.
So this is the next article, very similar in terms of single institution, a long-term follow-up now of a 3-armed randomized controlled trial. Same total knee design, but different fixation strategies. And they, again, looked at similar outcomes. Their results were a little bit interesting in that the survivorship was actually better for the cementless version rather than the cemented. And there's some editorial that it has to do with the implant specifically that they were looking at. So my question to the panel is, what's the best methodology for studying this question? Is it large registry, national registries, or is it institutions where you can kind of like dive into the individual implants themselves? What are the panel's thoughts about the best methodology to study this question, if there is one?
Yeah, I think the best methodology is going to be kind of these large database studies, because you're getting all comers and all types of surgeons. And really what you're concerned about is survivorship here for revision for loosening, in my opinion. I mean, you kind of touched on that on the earlier article. When you're looking at functional outcome scores and things like that, there's oftentimes a lot of bias based on the age range of the patients that I gave that I do cementless knees on. And so I kind of always take some of these articles with a grain of salt when they say, oh, you know, they're discharging home quicker, they're meeting certain functional outcome scores at an earlier time point. And that's true because they're 55 years old and they're active versus the 80-year-old you're cementing.
All right, some additional questions. So for Alfred, what factors or level of data would you need to see to make a switch?
Honestly, I've got probably unrealistic expectations. So long-term outcomes, so 20 years, cost, data to justify it, and also some unbiased, if that's possible, analysis of qualities based on PROMs. So again, cost data, long-term outcomes.
So on the topic of long-term data, the long-term data we have now are on the earlier generations of cementless devices. To wait for the long-term data on the current cementless devices, we're probably going to be moving on to something else by then, don't you think?
I agree. That's why I said it was unrealistic. And that applies generally to arthroplasty because it works pretty well. You make a change, like you go to kinematic alignment, you do a medial stabilize. It's going to take a long time to know. And by that time, we're probably doing something else.
Yeah, the good news is I'll be too old and I'll be dead by then, so I will never switch. So.
Yeah, I mean, Jay, you sort of nailed this one in terms of thinking about how to make some of these decisions. But there's so many new bells and whistles that are coming down the pipe. How does one individual surgeon sort of factor the cost of the technologies into their actual clinical practice and what they're going to treat their patient with?
I think the first thing is patient outcome, and then comes cost. If there's a technology that improves patient outcome, like highly cross-linked polyethylene when that was introduced, that was costly. Companies were asking for a premium, but that was definitely a justified investment because it changed people's lives. And that has been one of the greatest accomplishments, I think, in arthroplasty. The others I remain a skeptic about. So robotics being one of them, uncemented fixation being others. Right now, and again, of course, I'm biased, our major issue is infection. I want to see what industry has done to address that problem. You tell me about one innovation in the last 10 years related to prevention, diagnosis, or treatment of infection. There hasn't been a single one that I can remember. Yet we're seeing every company jump on the bandwagon of bringing robots at additional costs, cross-sectional studies, cementless fixations. We're going down the same path of having technologies that have ended up hurting our patients, modular femoral stems, metal on metal. The list is long and large. So I think surgeons owe it to their patients to look at the data carefully before they embrace any novel technology.
May I ask a question?
Yeah, of course.
So, Dr. Parvizi, so you had some great preclinical studies looking at coatings and antibiotics, and the cost is prohibitive, but then the benefits would be outstanding. Why don't you think industry hasn't been more aggressive in pursuing that?
Well, they have actually. So to be fair to industry, they have done incredible innovations on that front. I think the bottleneck is the regulatory approval process right now, which needs to change. And I think the FDA is going through those changes. They are now listening to our needs. Most of those technology have been stifled because of the regulatory requirement. So hopefully we will see some of those novel technologies, including like nanotechnological alterations of the surface. There's an ongoing clinical trial in Australia currently that's looking at nanotechnology, and the results are so far extremely promising. So great question, Albert. And I don't mean to sort of sound negative on the industry, and I'm not. I think they contribute immensely, and I work with industry myself. But I think the surgeons owe it to their patients before embracing a novel technology to see the data and to make sure that it's not just status quo, but it's going to improve the outcomes. And if uncemented knee replacement does, then we will know, and it will get reflected in the literature soon.
So the next topic I wanted to address is alignment. So this is your patient, 67-year-old, basic UCSF cohort of comorbidities, and is actually more symptomatic on the left. The radiographs demonstrate windswept knees. So how do you all think about alignment with total knees? And in talking with the patient, what may you say? This patient says, I've got this bow leg on one side and a knock knee on the other. How do you counsel that patient about what they might expect post-surgery? I'll just go down the row.
Sure. So I talked to them a little bit about alignment, saying that we can straighten out their legs some. I'm starting to kind of delve into more patient-specific alignment techniques with robotics. I think it's difficult to do without robotics and be precise, or some sort of computer-navigated technique. But I think this is something that's still fairly new as far as whether or not it's going to be here to stay. But it seems like everybody in the field is kind of moving towards this patient-specific alignment rather than a true mechanical alignment.
Alfred?
So basically, most of our patients come in, they say they've got a crooked leg. We generally tell them that we're going to straighten them out. Agree entirely with Keith's statements about potential for different alignment than just a neutral mechanical alignment, but we still do the neutral mechanical alignment.
Same here. But if the x-rays look bad, then I'll say I did a kinematic alignment.
That's right.
So am I a dinosaur and still getting scanograms and having trainees draw sort of cuts on the bones, drawing the difference between the mechanical and the anatomic axis of the femur?
Well, I think this is great educational material, and I think it actually adds to your preoperative knowledge, and it might have some bearings on how you do the surgery intraoperatively. So no, I personally don't think this is unnecessary. I mean, I don't do it on every single patient, but I think if you're in an institution like UCSF where you have residents and fellows that you're training, I think it's a great idea.
So yeah, I mean, I'm a traditionalist in terms of sort of mechanical alignment of my total knees, but we've sort of talked about these new sort of alignment strategies, and I find a lot of confusion in the terminology. Kinematic, reverse kinematic, restricted kinematic, all of these types. But when you see a knee like this, Keith, if you are dabbling in alternative alignment strategies, what's going to be your goal for this patient?
So somebody with a difficult knee like this with pretty significant deformity and bone loss, I'm actually going to revert back to kind of a traditional sort of gap balance PS knee technique. And I think it's fine to kind of stick with a kinematic alignment philosophy here. Sometimes it's going to be hard to get that person all the way back to neutral. But I think in some of the more difficult knees, I do shoot for mechanical alignment and try to get them back to neutral.
Yeah. So do we think that adopting these individualized versus universal alignment strategies are actually going to mitigate some of this patient dissatisfaction that we see with total knees?
I think we really don't know. I mean, I think we're being told this, and it's interesting technology and sort of philosophies, but, kind of like Jay said earlier, that, we're going to find out with the data.
Alfred, what are your thoughts on this being one of the main sources for the percentage of patients dissatisfied after a primary total knee?
It's a very interesting area. So if you look at probably other healthcare professional literature like therapists, you'll see that satisfaction may be even higher than our orthopedic literature, but there have been studies indicating that perhaps that 20% dissatisfaction is actually lower than what really is there. My dissatisfied patients, I don't think generally are technical issues. It seems to be mainly other factors, whether it's psychological or, emotional coping strategies. So I think it might affect it, but I don't think it's going to drop it from 20 to 5%.
I agree. I just don't think we know enough about the dissatisfied patients and whether alignment plays a role in that or not. It's hard to know.
So there was a lot of concern initially that putting these knees with an oblique joint line would lead to failures and ultimately revisions. Is anyone on the panel still concerned about the survivorship of implants based on this joint line obliquity?
I would say yes. I mean, I think that, we really don't know with these alternative alignment strategies the long-term survivorship. And I am concerned about putting somebody's tibia in, 5, 6, 7 degrees of Eris based on what the robot tells me. And I mean, when I do use robotic technologies in total knee, I kind of have a sort of bounded philosophy in that I won't put them in certain alignments over a certain degree.
So you override the robot.
I override the robot.
Nice tool to have.
So just polling the audience, how many are dabbling with alternative alignment strategies in primary total knee? Dabbling or veterans? Okay.
So a question to that, as you're dabbling, is it because you're not happy with what your patients are telling you, or is it because these new alignment techniques are available because of new technologies and offerings?
Nobody wants to answer that question honestly, huh?
Well, I'll move on to the article that I found that was recently published. Another randomized controlled trial, long-term follow-up, published by the Mayo Arizona group. They looked at 88 patients, kinematic versus mechanical, kinematic done via PSI. They had a mean of 13-year follow-up. They looked at reoperations, complications, and a number of PROMs. They found no difference in major or minor complications between the groups, and again, only one small difference noted with the KA patients reporting a non-significant improved satisfaction. So I think one of the challenges I have is, Jay, you did a great job on getting everybody on board with a universal definition of infection, but we don't have a universal definition of kinematic alignment. So if I say I'm going to shoot for mechanical alignment, then I'm shooting for mechanical alignment. But for a given patient, that kinematic alignment's going to vary. So how do we study that question when there's so much variability in the data? Keith, since you are, a kinematic person.
So I guess full disclosure, I probably only do kinematic on probably 30 to 40% of knees. But since I've been deemed that, I think that, with these newer technologies, I think they're going to eventually become data gathering machines and hopefully be able to relate that to outcome long term. I think that's kind of the promise and the goal for surgeons and patients alike with robotic technologies. I don't think we're there yet, but I mean, eventually I think they're going to be data gathering machines that eventually will be able to let us know, whether or not we're making improvements with kinematic alignment or if we're not.
And this basically looked at all the randomized controlled trials that have been published on this topic, and to cut to the chase, there was no significant difference in outcome measures. So do you think that this is because we're not looking at the appropriate outcomes with the ceiling effect of our current PROMs? What should we be measuring to differentiate between these two techniques?
Yeah, I agree. I don't think we have a sensitive metric to be able to pick up the subtle difference between them, if there is any. So to your point, Eric, I think a lot of work needs to be done on defining these properly and also aiming. Survivorship obviously is a very hard point you could measure, but for those you have to wait for a long, long time. So I do think we need to really change the way we're examining the difference between the two.
So the question I have is that, okay, we can't find a difference, so we need a better ruler to show a difference. So at what point is what we're doing satisfactory for, looking at satisfaction or whatever other patient-reported outcome versus just an impetus on our part. We think we have a hypothesis that there should be a difference, and because we can't find it, it's because of our techniques. So just a philosophical question.
Now we're going to move on to technology and robots. This is a patient with JRA, obviously had multiple arthroplasties before, recently a left total knee, and now wants the right total knee. Clearly, you can't use an intramedullary femoral device, so in your practice, Keith, you're using a robot?
Currently, yes. So prior to that, I was using more handheld navigation before we had access to robots, but currently I would use a robot for this.
Alfred, what would you do to?
So we have a robot. I don't use it. I'd probably use an accelerometer-based technique to get the alignment.
Jay?
I mean, obviously, I don't use a robot, and it's going to be challenging to get the guide into the femur. This would be one that I would refer to one of my partners who uses robot on a regular basis. This wouldn't be one that you bring the robot in for your first case and try it on this patient.
For the audience, how many would use an accelerometer for that distal femoral cut? How many would use traditional navigation? Robot? And anything else that PSIs, patient-specific cutting blocks? Yeah, so a good range out there. Maybe down the road, I probably know the answers for the last two, but what percentage of your practice, Keith, is tech-assisted?
So it's about 30 to 40%. And there is a difference for total knee and total hip. I don't really use much technologies on the hip side, at least not computer or robotic navigation. But about 30 to 40% on the knee side. This is based mainly on where we have robotic technology, but it also has to do with teaching, being a teaching institution, teaching fellows, and so I do still want to teach them manual techniques for total knee arthroplasty, because I think there's some danger in trainees coming out only doing technology-assisted total knees.
So that's going to be one of my later questions, but since you already brought it up, so how do you balance that in your fellowship?
So for me, it's easy because the place that we have robotic technology is a place that I don't have a fellow with me. So I'm actually doing that on my own with my PA. And then we use traditional manual instrumentation at the hospitals for total knees and to teach the fellows. We do have robotics now at the hospital, but we rarely use it. Every now and again we will, just to show them the technology, but I don't want them to be reliant on it.
And what was your adoption curve?
So we first had it at our surgery center. I would say, after 10 or so, I felt competent, and I'm probably about time neutral after, I would say, about 50.
Did you have a question, Alfred?
Oh, just a comment. In our practice, again, we do have a robot. Overall, I would say that amongst our partners, perhaps 5% are robotic, arm-assisted, and it's mainly for teaching and giving another perspective for the residents.
So, Keith, you had mentioned it provides a lot of data. Is that what you think the true benefit of these new technologies are for the practice of arthroplasty? Data?
I think eventually it will be. Right now, as you can tell, even industry-sponsored studies are not showing much difference in outcome measures. But I think eventually trying to go back and see some of those patients that had good outcomes, or maybe they didn't have a good outcome, and trying to glean the differences between certain subsets of patients by looking back at this data, the way you may have balanced their knee or set their alignment differently, and did that have a kind of bearing on their outcome.
So this paper was one randomized controlled trial on this topic in the past year, with the primary outcome being the WOMAC functional score at 6 months. And they didn't actually find that difference, but they did find a greater improvement in the WOMAC pain in the robotic group at 2 months, which sort of fell out at 6 months. I think probably the most interesting study that I saw in the literature is it hasn't been completed yet, but it is a multi-center randomized controlled trial out of the UK. They are going to include sham incisions for the arrays, and they're going to have blinded operative reports. They're going to need over 300 patients to provide a 90% power to demonstrate a MCID for the forgotten joint score at 12 months, and then they will obviously collect additional endpoints as well. They're also going to look specifically at sort of the learning curve through young surgeons training with the robotic system, and include, most importantly, I think we talked about a cost effectiveness model to look at the actual benefits of these robots. So I think we've probably talked about some of these. We talked about the balance of the education, but what outcomes should studies comparing robotics versus manual total knees really focus on?
I haven't seen any economic studies. Mm-hmm. Have there been any of those? So I assume robots is cheaper. So again, for the given amount of investment, does that justify the adoption of a technology that increases operative time? Keith said he's time neutral. I find that difficult to believe that actually robotics, with all the stuff that you do, makes it. I mean, I believe you, but it's really, really tough to be time neutral. The capital cost, the additional exposure of the patients to cross-sectional studies, and hopefully imaging, hopefully they will go away. And then on top of that, the disposables. So all of those that we're investing in at the moment, with the limited resources that CMS tells us that we have, is that justifying the outcome or not? And I think those are some of the things that we need to look at.
A teaser for tomorrow, I'll comment on the economic data for robotic versus manual total hips, and it's a bit interesting.
Now we're going to switch gears to bearing choice. So pretty standard total knee patient. Keith, what's your bearing of choice?
So I've pretty much switched to medial stabilized, medial congruent poly bearing at this point with a CR femur. I was trained traditional PS gap balanced, and now I've pretty much migrated most of my practice to a medial stabilized or medial congruent construct.
And that for all comers, other
Yes.
than severe deformity?
Yes.
Alfred?
So bearing choice based on materials or design?
Design.
Design, okay. So yeah, there's new data on medial stabilized PSCR. Others, they look pretty similar. It's, as we discussed, I would say relatively new. It'll take a long time to see if there's any meaningful difference. We still do PSCR. So it depends on the status of the PCL.
Yeah, mostly PS, but I agree with Keith. I think the data on medial congruentus look really, really promising. Emerging data shows that that's perhaps something we should consider, particularly in some of these severe deformities.
So Keith, why did you switch? You said you're a traditional gap balance PS, and now you've gone to medial stabilized.
Some of the data, looking at these medial congruent, medial stabilized designs, but also kind of just got tired of listening to the patients talk about the box post kind of noise that it makes, and just not want to cut a box. Be more bone preserving.
Do we think bearing choice is a clinically relevant issue at this point in time, whether someone gets a CR, a PS, or ultra congruent medial stabilized?
Probably not. I think the data has shown that.
I agree. The only thing is whether modular versus all poly tibia. Mm-hmm. Definitely all poly tibia seems to have better survivorship. It obviously is less expensive, but for some reason there's been, less of an enthusiasm to use all poly tibias.
So this is just a study looking at the UK National Joint Registry, comparing the four designs here: cruciate retaining, posterior stabilized, mobile bearing, and medial pivot. They looked at all-cause revisions. You had over 1 million total knees, the predominant being cruciate retaining, followed by posterior stabilized, and a fraction of the other two. So the medial pivot and the cruciate retaining had the best survivorship at those two, in the sort of 95%, which was statistically significant, whereas PS and MB were at 94.5. So does that matter, 1%, that you're demonstrating a difference between these? If you tell a patient that they have a 95% survivorship, whichever polybearing they have, I have a hard time sort of taking this data and changing practice. Anyone else?
But 1% could translate to almost 3,000 to 4,000 patients in a large patient population of 1.2 million, right? So in America, we're doing about, 800,000 a year. So 1% for 800,000 is a substantial number. Mm-hmm. So yes, it does, in a large number when you're looking at it. And then on top of that, I think it's actually a functional outcome with the medial pivot is thought to be better than all the others.
So talking about function, this was a systematic review, again, comparing ultracongruence versus either CR and PS. They only took level one or two studies. The ones that compared them to CR showed no difference in either functional or knee flexion, and the posterior stabilized compared to the ultracongruent actually had better femoral rollback, AP stability, but no other significant differences. I think we're probably at time. You want me to just wrap it up here? Okay.
5 minutes. Audience questions.
Yeah, okay. Well, why don't we just end there? Thank you to my panelists for participating in this dialogue. We'll open it up to questions from the audience about any of the topics that we reviewed or other debates in primary total knees that kind of you've been thinking about.
Thanks for a great session, guys. Just to get back to the cementless discussion, probably the most impactful data that's come out of American Joint Replacement Registry was from 2 years ago, looking at cementless versus cemented fixation in primary knee replacement. And the initial signal was at 8 years that males less than 65 had improved survivorship compared to males older than 65 with cementless fixation. And then the following year, we were able to show that all males had improved survivorship at 8 years with cementless fixation. That's not the case for females still. So that's probably the most applicable data to our United States practice as a whole. And, you know, gender or sex is probably just a surrogate for bone quality. So there's some interesting work being done by Dave Mayman at Hospital for Special Surgery where they're looking at bone density on CT scans. And they're hoping to try to come up with a bone density score that could say that this is sort of the threshold where we think a cementless knee would be okay to use, and here's the threshold below this, you're going to probably need to use a cemented knee. So that's probably where this is headed.
You know, Hutch, I don't know, men are weird when it comes to knee replacement. Because if you look at Dee Steiger's work from Australian Registry, he showed that the survivorship for males was much better when you use the navigation. And then that trend reversed after 10 years. So I would wait. I think 8 years is a still early time point. And for some reason, males seem to have a different type of an outcome with any time and technology is embraced. Again, I'm not saying that's not what we should do, but it just has to really justify the additional cost, and we just need to wait a little.
Yeah, no, I definitely share your caution.
And I think industry has been very aggressive in trying to push these uncemented, and not all uncemented designs are the same, by the way. So there is definite, almost twofold difference in the outcome of uncemented knees. And for today's purpose, we've been putting them all under the same umbrella, but they're not. There are differences in the uncemented designs as well. If you look at the registry, I don't know if HIRR has the granular data to make a distinction between the different designs. You probably know the data from other registries, but important for us to also look at, because every company is now jumping on that bandwagon and bringing their uncemented knees, and the results of uncemented knees are not the same.
Yeah, the 8 and 9 year survivorship in AJR is heavily dominated by one company.
One company.
Yeah. And I also want to point out this is not an altruistic endeavor. So cementless is no cement. It's faster. And with our declining reimbursements, anything that faster allows us to do more work. So there are other factors at play that have probably affected early adoption of this.
Any other questions or comments from the audience, or we'll, I guess, transition to our first break of the morning?
Hey, Eric, I just wanted to ask one question of the folks, Keith, maybe Eric, who are doing medial stabilized and with respect to the PCL. So, Keith, you and I were talking about this last night, but you're taking the PCL and everybody with the medial stabilized, leaving it in some select folks. Did you do that all at first? What's your philosophy on that? And what do you think, talking to other people, what do you think the pros and cons are of that?
Sure. So I take the PCL in everybody. I think the big pro is I think it's a little easier to balance. And I come from kind of a PS gap balance technique. And so it's more similar to that. I kind of transitioned to sort of a CR ultra congruent design before the medial stabilized, but even then took the PCL on every patient just because I think it's easier to balance.
Yeah, I mean, my experience was similar to Keith's in that I just was getting tired of patients complaining about the clunkiness of the PS, but my workflow hasn't really changed. I think the one thing that I have seen, though, is we get max flexion laterals at 6 weeks, and I think if I were to be honest with myself, I get more femoral rollback with the PS knees than the CR femurs with the ultra congruent polys. Mike?
The cementless, the topic of hybrid didn't really come up. And if you look at the data, most of the loosening of cemented knees, when it does occur, is on the tibial side. The femur and the patella are rarely loosened. And how much of an option is a hybrid knee with a cementless tibia and cemented other components? Is there any data on that? When you look at the cemented versus cementless data, is it all cemented and all cementless?
Yeah, I mean, the one study that was out of Mayo, they called basically hybrid fixation of a tibia. That was a specific design where they had cementless 2 pegs and then they surface cemented. But, the term hybrid can mean a number of different things. And I don't think there has been any large series where it was actually a cementless tibial base plate cemented femur or vice versa. I don't know if anyone else has read anything with that sort of combo.
Well, the initial hybrid trial that was published, hybrid had the worst outcome than the cemented knees. But then again, Mike, you probably know that design, it didn't have a very good porous surface for osseointegration. So the initial uncemented designs were suboptimal, but hybrids did worse than cemented and cementless in the initial trial.
All right. Well, thank you all for your participation this morning. We are going to enter our first break and plan to be back by 10:30 for our first keynote speaker.